Welcome, Naheed. Thanks so much for taking part in this conversation. Would you like to just introduce yourself and tell us a little bit about yourself?
Yeah, thanks for chatting with me. My name is Naheed Dosani, and I'm a palliative care physician who spends a lot of time providing healthcare for people who experience structural vulnerabilities like poverty and homelessness. I'm the founder and lead of Canada's first and now largest mobile palliative care program for people experiencing homelessness, the Peach program. I'm the medical director of Toronto's largest hospice, Kensington Hospice, and I work as a palliative care physician at an inner city hospital, St. Michael's Hospital, where I serve as a clinician, educator, and as a researcher as well.
Brilliant. So you already covered three widely different areas, and I would like to know about how does your clinical practice differ in each of these areas?
Yeah, absolutely. I think that in truth, when serving people who live in the community, particularly doing outreach, working in respite shelters and drop-ins, the approach to care often really has to be different because the focus of the issues that we see for people who, for example, experience precarious housing aren't always necessarily medical issues, or if they are medical issues, they're the result of indirectly the result of other issues upstream, like not having housing, not having food, not having money, or not having the social supports to get to medical appointments. And so when I work in the community, when I'm doing peach outreach visits, when I'm supporting people and transitioning them, for example, to our hospice program, which is a program called Radical Love, which is an equity-oriented hospice palliative care program, there's a lot of attention paid to the social determinants of health, the kinds of social factors that people may or may not have, and also an attention to the structural determinants of health, which often are the determinants of the social determinants of health and inequities in them. Things like colonialism, things like racism, things like discrimination and oppression and classism, or even ableism, for example. A real analysis of those issues allows me to meet people where they're at in really unique and important ways. And I don't think I'd be able to care for people in the ways that they really need if I wasn't able to pay attention to them. I think with that said, I don't want to say that when I'm working in the hospital that the social and structural determinants of health don't matter. It's just a different kind of setting where, people are in a setting where it's a healthcare space. It's a space that's home to healthcare and healthcare workers. And what I'm more in tune, I'm always in tune with this, but I'm very in tune with this in hospital is the ways that sometimes healthcare and healthcare spaces can be traumatizing for people. Many people I care for describe hospitals, for example, and other health facilities as places of trauma, places where they've been hurt, places where they've not been treated well. And so I really try to practice in a way that really anchors and centers concepts around trauma-informed care. The idea that, I'm working in a system and acknowledging that I'm working in a system that has harmed people, but doing things that can be informed in a way that reduces that harm or reduces that trauma. Everything from learning how to pronounce someone's name, learning their preferred pronoun, or sitting at eye level with them in a way to make them feel more comfortable. And so, depending on the setting, you might think about some of these factors a little bit differently, but really it's about meeting people where they're at, regardless of the setting.
And 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 from if you're talking about street community and people who suffer from poor housing or homelessness, the idea of bringing them into an institution is pretty tough anyway. So, how have you gone about changing your clinical practice to be able to support the people in the ways in which they need, um, given that they're not even going to want to come into an institution which we may think is a gold standard, but may not be relevant to them.
Well, actually, I think you hit it on the nail there to say that actually the real way that we've had success in supporting people to be able to interact with the health system, enter into a hospital space, for example, if they need it, is to actually take our agenda, what we think is best, and throw it out the window. Sometimes too often in healthcare, we think we know best, and we're well intentioned. Don't get me wrong. I'm not saying anyone's being bad or trying to do bad things, but sometimes we think we know best, and we don't really understand the circumstances and experiences of the people we care for. And in truth, this is what we really mean when we're talking about meeting people where they're at. It's about taking that agenda, taking what we think is best, and really throwing it out the window. I mean, I have a colleague, Dr. Maury, who works on our Peach team, and he always talks about how that initial visit should be less about filling out a checklist or completing our palliative care consultation template and making sure all the boxes are filled appropriately. Actually, the goal of that first initial visit for equity deserving populations should really be that we get to a place where they invite us back. And if they invite us back, then we've succeeded. And that means we might have met them where they're at. We might have overcome some of the trauma that they've experienced, and we might have actually succeeded in delivering person-centered, trauma-informed care. And so I think that's really key to the approach. I think the second thing is I've always promoted and have been a supporter of healthcare models and palliative care models that don't center, one type of discipline, for example, physicians, and actually center around the people we care for.
So it sounds like uh, your clinical practice that you do out in the communities, particularly with people who suffer structural vulnerability, has informed. I'm thinking, your Radical Love program, but clearly that's informed the way that you conduct your service in your service design in the hospices. Is that right as well?
Absolutely. This has been an incredible journey that started, out the back of my Honda Civic, driving around one day a week, providing outreach for precariously housed people. And fast forward to 11 years later, it's a robust 24/7 program that provides palliative care, even mental health and psychiatric palliative care, nursing, social work, health navigation, peer work, and all the bits. And what we've learned it's not just that we feel this is the right thing to do, but it works. This care has been so effective in that it's allowed for people that we care for to engage better. They're using emergency departments and hospitals a lot less, and they're seeking out a form of continuity of care they seem to have not seeked out in other spaces and places. So what we've done is we've extended that care into the hospice setting. As medical director of Toronto's largest hospice, Kensington Hospice, which is a 19-bed hospice in the inner city of downtown Toronto, we've extended that peach philosophy. We call it that radical love philosophy, and we've created a program called Radical Love. What is Radical Love? Radical Love is a suite of interventions that we've implemented at the hospice level to really prioritize equity and justice-based hospice palliative care. We've redesigned our data collection processes. We redesigned the way we triage referrals, the way we assess need, for example. We've enhanced education and training for clinicians within the hospice that focus on things like cultural safety or trauma-informed care and harm reduction, for example. And we've implemented new roles like having health navigators and peer workers working within the hospice. The outcomes in just, 2 years have been tremendous. We went from a hospice that cared for structurally vulnerable people less than 2% of the time to now a hospice that cares for structurally vulnerable people around 40 to 50% of the time. And that is a phenomenal jump that we've seen. And there's been an acceptance and a support among staff and a culture change, really. And so we're firm believers that radical love is something that doesn't need to just sit at Kensington Hospice in downtown Toronto, but this philosophy, this approach, this radical love palliative care approach can be applicable to any region, any community, and in any country to inspire equity-oriented hospice palliative care.
So I'm just going to tease out a couple of things here because you mentioned some things which I think are fundamentally important. And the first thing is, radical love and talking about love in the palliative care setting. We don't do that. We talk about what's wrong. We talk about deficits and symptoms and needs. And actually, love and that connection and belonging is the thing that if we don't talk about that, we're not talking about the things that are most valuable to people. And the other thing that you're talking about, which I think is really, really important, is that you're not just selecting a small group of people who've got uh, chronic terminal illnesses. You're talking about all the people who traditionally miss out on palliative care services. And once you start the list, you then start talking about, obviously homelessness, but then you talk about ethnic diversity, cultural diversity, you start talking about LGBTQ plus populations, prison populations, the list goes on and on and on. And it sounds to me like you've addressed that problem and that you've seen a much broader range of people come into your hospice and use hospice services.
Yeah, yeah, no, absolutely. Those are very important points, Julian, and I do agree with you. I think it speaks to a broader issue that when we are able to provide a care model that focuses on care for structurally vulnerable populations, if we're able to meet those folks where they're at, if we're able to deliver person-centered care for those communities, then we are raising the bar of care for everyone. And that is why equity-oriented care is such a beautiful thing to focus on.
There are two things that you need to be able for people to follow this approach. One is changing your clinical practice, and the other is service redesign. And you've managed both, but you've done that by persuading whole services to take this on board. How on earth have you done that?
Yeah. One of the things with shifting these systems that are often associated with a lot of inertia is to remember that it's not always going to be easy. I think sometimes our story in Toronto around palliative care equity comes off as a success story. And while we're proud of the work we've done, there was a lot of rejection along the way. We failed a lot and we made mistakes. And, goes without saying that those are obstacles that need to be overcome. But how we've been able to convince policymakers and healthcare leaders along the way, I think, is number one, evaluate quantitatively and qualitatively the gaps and the impact of our work. By doing so, we've been able to use data as an instrument for justice, and use metrics as an instrument for justice. By putting together people's stories with numbers, we've been able to highlight gaps and show the impact that we can have when providing palliative care equity models and shifting resources to support those models of care. I think that the second thing that we've been able to do is to really draw support from a compassionate public. We've utilized different forms of media, including traditional media and social media, telling the story of the people we care for through their eyes and giving them the platform to be able to tell those stories. Through those opportunities, we've seen incredible support from the public about our mobile models of palliative care through the Peach program, about hospice-based models, and how the public is seeing that, it's not right that, people who experience health inequities in their whole life then are also experiencing health inequities when they die. And so that immense support has lended well when advocating for more resources for our programs. I think the third thing is we've planned for the future workforce that's going to do this work. In all the spaces I work in, whether it be hospital or community-based work through Peach or at Kensington Hospice, we have built robust medical education programs that really focus on health equity and its intersection with palliative care, such that we've developed a partnership with the University of Toronto so that every palliative care resident that goes through training rotates with the Peach program, for example. And many spend time at Kensington Hospice providing palliative care equity care and learning on the ground of what it's like to provide palliative care on the streets and in shelters and in community-based settings as well. And so that's one example of many of how we're trying to really expand our educational offerings so that down the road we're helping graduate health workers who not only are saying they want to do equity-oriented work, but are walking the walk as well and can walk the walk because they have the skills to be able to do so. And so I think those are three ways that we've been able to convince policymakers and healthcare leaders to support this work.
I mean, that's absolutely outstanding, Naheed. Like,
Thanks, Julian.
chapeau.
Thank you. You're too kind.
I mean, that's you hit the nail on the head that if the system is going to change, the professional palliative care workers have to change, and they, like you say, they have to walk the walk. I mean, they're not even talking the talk at the moment for the most part,
Right.
you know, and seeing how it's applied in clinical practice and service redesign is absolutely key, fundamental. So what you're
For
doing,
sure.
brilliant. Nothing
Thank you.
but brilliant, yeah. And and it's interesting that Canada has got these beacons of health equity work. With you and Kelly and Holly and Mary Lou and all of that. And man, it's outstanding, really.
It's really been an honor to be part of this family, and there's it really is a family of support, coast to coast to coast, and people like Mary Lou and Kelly and Holly have been mentors of mine and continue to be mentors to people like me and so many people. So it's important to do the work, but it's important to recognize that the work that we are doing is not ours. The knowledge we are generating is not ours. It's the communities. It's the community of people with lived experiences. It's really the people we serve. And so having that humility and recognizing that this is a two-way exchange of knowledge is really what has bonded, the various, beacons of hope, as you call it, across the country. And I'm really grateful to be a part of that family.
Wow, we made it to the end.